I'm Jolene Carvalho, and welcome everyone. Being here early on a Wednesday, on a Tuesday, just towards the end of the meeting, to talk about an interesting topic. Abnormal heart rhythm, how to diagnose and how to manage. There's a lot to cover in this presentation, and I'm going to try and briefly tell you how to assess the normal cardiac rhythm so you understand what it is in the fetus. To diagnose and manage irregular rhythm, which is quite simple, but people get quite confused on how to deal with these babies. How to diagnose and how to manage antepartum bradycardia, and how to diagnose and to manage tachycardia, so it's basically everything. So if we start with the normal cardiac rhythm, just to recap, I think most of you are obstetricians, the normal rhythm is called sinus rhythm, is regular. It has a 1-to-1 atrioventricular conduction, and it has a constant, what we call AV or atrioventricular interval, which is the delay between the atrial and the ventricle contractions. So if you look at this diagram here, well-recognized four-chamber view, the normal sinus node is located in the right atrium, right at the top, and then is a pacemaker of the heart. It sends a stimulus which travels down the atrial chambers, and it hits the atrioventricular junction, where there is a slight delay of milliseconds, and then that impulse is generated through the ventricles, and then we have ventricular contractions. So for every heartbeat, we have one atrium and one ventricular contraction with a slight delay, which is the AV interval. So most of the time, we assess the heart rhythm by eyeballing. You look at the heart and it looks regular, and you get used to that pattern, and we don't necessarily go on assessing the rhythm, although it might be a good idea to assess the rhythm in a normal heart, because then you get used to how to assess this. When you have an abnormal heart, you have the practice. So how to assess without just looking and observing a normal regular rhythm? We have to have a method that assesses simultaneously, and it's very crucial, this simultaneously, the atrial and ventricular activity, so we can see how they are coordinating. There are different methodologies for looking at that. Ultrasound being the most important for us here. There is fetal magnetocardiography, which is based on magnetic field, and fetal electrocardiography. They have their problems and they're not widely used. And we are in the Society of Ultrasound, so obviously we're going to concentrate on ultrasound, which is what we do on a regular basis. So we can use M-mode cardiography, which is the traditional way, first described. We can use post-wave Doppler, and there are lots of sites, again, in the literature that have been published to see where you can assess, and each person may be familiar with one or another. But it's a good idea to know at least two methods, because one may sometimes be difficult, and you can get away with the other one. And tissue Doppler as well has been described, but I think it's not as widely used as M-mode and post-wave Doppler. So if we start with an example of an M-mode, if all the M-modes were as clear as these, no one would be looking for other methodology. But we know that it's not always possible to get a perfect signal of the atrial septum here and the ventricular septum. So you put your M-mode line crossing through the ventricles of the atrium. You can cross through the ventricle and through the atrium and the aortic valve, for example. So you can do it from different places. But this is the most common one on the M-mode. And you have an atrial contraction, you notice the atrium, and then following that, a slight delay, because it's a time domain, slight delay for the ventricle, atrial ventricle, so this is a normal, regular sinus rhythm. There are lots of sites to look at the Doppler signal. That's my preferred one. I've described this many years ago, more than 10 years ago now, to do pulmonary vessels simultaneously, pulmonary artery and pulmonary vein, and this is the classical, comes from the paper in 2007. You can see here you put a sample volume in the atrial, in the lung parenchyma, wide enough to capture artery and vein, and you have your atrial systole, and you have your ventricular systole going towards the lungs. So this is kind of look a little bit like an electrocardiogram for the cardiologist, a P wave and a QRS complex, and you can see very clearly the relationship between atrium and ventricle. It's much easier to obtain these than obtain an M-mode in the majority of babies, but M-mode has its advantages as well. So basically you do at the level of the four-chamber where you can see lots of pulmonary veins and arteries, so you can sample from here, from there. You're not dependent on angle because you have lots of sites to sample. You're not dependent on having a good four-chamber view because you're not sampling through the four-chamber, so really you need the Doppler signal, and color helps that. And you put a relatively wide 2 or 3 millimeters sample volume, and you capture the two signals simultaneously, and it's a blown-up picture of the pulmonary arch and pulmonary vein. You've seen some of the live sessions. It's very easy to get. So atrial systole and ventricular systole, regular and one-to-one conduction. There are other methods described, like mitral valve inflow and left ventricular outflow. You have your A wave in the mitral valve signal and the ventricular on the ejection through the aorta. I think this is very easy to look at the normal rhythm. I find it, to me, more difficult to assess an arrhythmia very quickly. I prefer the pulmonary vessels. But if you're used to this, it's the same understanding. The group from Canada, Professor Fouhon, described this many years ago, which is a simultaneous sample through the superior vena cava and the aorta, where you have here the SVC and a reversal flow during atrial systole in the superior vena cava and the signal in the aorta. And again, you have a one-to-one conduction. So there are lots of options. You can choose the one you feel more familiar with. So that's enough of normal rhythm. We're going to move on to irregular rhythm. I don't know if this is going to work. The sound is off. I had a sound of an irregular rhythm, but the sound's cut off, which is what you hear, or the midwives or the obstetricians hear in the antenatal clinic. So when you hear that, you don't have the ultrasound, you don't have video clips, and you have to see how I'm going to manage this woman who came to antenatal clinic and the rhythm is irregular. While it's irregular, the most common reason are ectopic beats, but there is that tendency to describe to the woman there is a missing or is skipping, and those words can have a big psychological impact on the woman because she thinks there's something missing in the heart. There is, but it's not the same interpretation she might have. So those words are quite dangerous sometimes. So most of the time they're fine. Most ectopics, 95%, 98%, no problem. If you reassure the woman, send her away, you will be fine most of the time. The problem is, sometimes it isn't. So 2 to 5%, there is an important reason behind that, and it's how to stratify and how to get those cases that need to be referred. So it could be that underlying that irregular rhythm, we have a significant arrhythmia, and we have a congenital heart disease. We can have a rhabdomyoma, we can have pulmonary trees intact septum, tense atrium, creating an Epstein malformation. So you need to stratify which babies are going to be seen. So that's, if the woman goes for a scan, that's the image of the heart, is irregular compared to the first one. You see every so often there is missing one there, skipping one. And this would be the corresponding of the atrial ectopic, which is the most common reason for irregular rhythm. So this is from the same baby that I showed you before. You can see A, and then we have an early one. So that's out of place. Remember, ectopic pregnancy, out of place. Ectopic doesn't come from the sinus rhythm. So we have an ectopic here, and then it goes on in normal rhythm. So this is an isolated ectopic, not very frequent. In the pulmonary arch and pulmonary venous signal, this is how it looks like. This is our A wave, and then we have an early one here, which is the ectopic. This is not conducted because we don't see a signal going through the pulmonary artery. In this one, it's conducted. We have two here close together. So this is an atrial conducted. This is an atrial blocked to the ventricles. So the gap between the two ventricular bits might be a little bit longer. And then it usually disturbs the waveform of the pulmonary veins following the ectopic. You can see the S wave here is much taller than the S waves in the other ones, and then it carries on as normal. So this is quite easy to see if you're recording your post-wave Doppler. So that's the irregular rhythm. Atrial ectopic is the summary. Most common cause of irregular rhythm, benign in the vast majority of cases, but there's a small risk of tachycardia, and how are we going to monitor that? This is an example of a baby that was having ectopics. You can see here the sample in the pulmonary artery, A, normal rhythm, normal atrial activity, regular normal ventricular activity, following the atrial activity, normal heart rate, and all of a sudden you're scanning for ectopics, and then one happens here a bit early, and here, and it triggers, that's atrial and atrial, there's an early one here, so that interval is shorter than that, so it's an ectopic, and it triggers a short period of tachycardia, non-sustained. The problem is if you document it for short periods, you need to follow that baby because it could go into tachycardia more often. So if you capture that at any point, you need to follow that baby. So that's a short period of heart rate of about 200 beats per minute. So intermittent SVT triggered by an ectopic is not benign. You may not need to treat, but this baby may go into persistent tachycardia and may require treatment. So how to risk stratify, we'll come back to that with some kind of flow chart, but it's very important is to know when you have an ectopic, what's the heart rate? Is it on the high side? Is it on the low side? People tend not to register the heart rate with ectopics, and I think that was the first point to stratify how we're going to manage these ectopics in the antenatal clinic. So I said most of them are fine, but it does not always mean that if you have an irregular rhythm, that you have an ectopic as an underlying cause for the irregular rhythm. So this one is a different clip from the one I showed you before. Could this be just an ectopic? Could this be something more important? If you look at that, it's kind of contracting in pairs, two together, two together, two together. And that is what you would get on your umbilical artery, your aorta, on any arterial flow through the baby. You have two together in a gap, two together in a gap. And these are from two different babies. One has a blocked ectopic, blocked trigemini in a certain pattern, and one has a 3-to-2 atrioventricular block. Completely different implications for the babies. Heart rate about the same, 101, 110. So we can't differentiate from the heart rate. If you look at the M mode through the two babies, it's crucial to have atrium and ventricle simultaneously. So the atrium on the bottom here on both of them, and then you have an atrial signal, a gap, which is the normal, an atrial signal, and an early one. So that is the diagnosis of atriectopic, and we have a normal one conducted, we have a normal one conducted, and we have an ectopic which is blocked. It's blocked because it's a pathological one. It shouldn't be there, and the heart has blocked it. And then we have two signals which are normal and a gap which corresponds to that arterial signal. Then on the other baby, we look through the atrium and we have atrium, 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 and you can see the interval is regular. So the atrium is going and doing its job from the sinus node. But that one is conducted, this one is conducted, and this one is blocked. So this is blocking a normal sinus node activity. So this is pathological. This is 3-to-2, 3 atrial, 2 ventricles, atrioventricular block. So this is pathological, completely different implications. This will probably take a bit more time for you to follow this, but if you're not used to this pulmonary artery vessel, you have an atrium, and an atrium is the same baby, an atrium, and then we have an ectopic, and again we have two ventricular signals. And this is how the 3-to-2 block would look like. You have an atrium here, you have an atrium there, an atrium here, another one here, another one there, another one there. So there are regular atrial activities, and one of them is missing because it's being blocked. So this is the kind of flow chart. I will break it down for you because it's quite confusing like that. So if we start from the top, skipped beats, irregular rhythm. If you have no other concern, quite often the woman is in antenatal clinics. What's the heart rate? And we can stratify that from normal heart rate, 120 to 160. They are isolated ectopics. You hear the ones here and there. There is no periods of tachycardia or bradycardia. Most likely they will resolve spontaneously. But there could be an underlying cardiac abnormality. So do I refer all these patients? No. The obstetricians, the midwives, the sonographers that can do the scan, they can do a quick scan, like a growth scan, make sure there's no polyhydramnios, the baby's moving, the growth is fine, there's no pleural effusion, there's no cardiomegaly, and you're happy with your screening views of the heart. and there is no period of tachycardia. So this is what's going to happen. So a quick growth scan, looking at those things, and you can reassure the woman. So most of the time, sometimes if you see another week has resolved, if it is still there but there is no other concern, there's nothing to be done. So you don't have to escalate the referral for this. If you're still concerned, if you can't be sure, then you can refer someone else to have a look, but it's most of the time unnecessary. But if there is any problem in that scan, there is polyhydramnios. Polyhydramnios may mean that intermittently that baby is having tachycardia and is building up some fluid. It could be that the baby will have pericardial effusion, a bit of AV valve regurgitation. So if you have any concern on the scan, that needs to be followed up a bit more with monitoring, with Doppler intermittent, to see if this baby develops intermittent tachycardia. And then if you have abnormal findings, either if you have the ability, you can manage that patient, refer to a cardiologist or a fetal medicine specialist. So that's a normal heart rate. If the heart rate is faster than 180 or is slower than 110, then we are defining tachycardia or bradycardia, and then that needs referral. Because you don't know the mechanism, so don't sit on it. If the baby is having tachycardia, it could be an atrial flutter with variable block. It could be that the baby has a heart block if the heart rate is on the slow side. So those need to be referred and be assessed by someone that can follow the cardiac rhythm. And then there's a group in between. When the heart rate is 110, 120, irregular rhythm, that group is probably the group that gets not referred at kind of with certain urgency, because the heart rate, yes, is okay, 120 is fine, 110 is not below 100, which is some concept of bradycardia. But that group is not very common, but that could be some of the pictures I showed. It could be blocked trigeminy, it could be a form of second-degree atrioventricular block. But this is the small percentage, the 2 to 5%. That needs urgent referral. So heart rate is crucial when you're trying to stratify which patients are going to be referred. So I hope that that is clear. We're going to move on to management of antepartum bradycardia, because during partum delivery, you know better than I do, I don't deliver babies. Now, from the American College of Obstetrics and Gynecology, the definition of bradycardia based on CTGs, it was done during labor, but they also say this is valid for antepartum monitoring. So baseline heart rate, bradycardia used to be 100, now is 110. That's the definition from the American College. So should be applied interpartum pattern, but also for antepartum observations. Now, if you haven't come across this paper, it's quite a nice paper from the US, looking at heart rate according to gestational age. So they have derived a centile chart, which you can see here, which has the 3rd and the 97th percentile. You can see the heart rate varies with gestational age, which we know, but it's not a static 110. So that's a rule of thumb. But babies who are below the 3rd centile, they have a relative bradycardia for gestational age, and that can be a clue for investigation of babies as well. So it's an age-dependent fetal heart rate, but based on centile chart rather than a simple 110 beats per minute. Now, we move from the ectopics. We're going to now go into the bradycardia group, and there are basically 3 groups. There is the sinus bradycardia, which has a 1-to-1 atrioventricular relationship. We have ectopic triggered bradycardia, bigeminy, trigeminy. And we have heart block, as we know that, atrioventricular block, pathological. So here we have 2 types of bradycardia. The one on your left-hand side is regular, but it's slow. And this one is slow, but is irregular. It's doing a pattern of 2 as well, and this is apparently 1-to-1, but we need to investigate that. So let's start with a regular bradycardia. First type to describe is sinus bradycardia. So sinus bradycardia is the normal rhythm we started off with, but slower. So here's a fetus that was referred, because at 29-week scan, there was a bradycardia noted during a routine assessment of the fetus. So what's the mechanism? It's regular. When we do our pulmonary artery, pulmonary venous Doppler signal, you can see the trace is normal, but if you measure the heart rate, 109. So 109 is, by definition, is also very borderline, but is persistent. It's not just a little bit of that and it goes up to 150. This was a persistent bradycardia of 100, 110, 115. So this is not normal. So that's the same baby. When we look at the history, the mother said, oh, my heart rate is about 55. And then my mother has always had a slow heart rate, and her heart rate is about 40. And it was. The grandmother, the fetus, came on another visit, and I felt her pulse, and she was going at 40, quite happy, never had any problem. So there is obviously a genetic problem in this family, but of no further consequence as far as we knew. So the grandmother, the mother, and the fetus, they all had a slower heart rate. I don't think we ever came to a genetic diagnosis. So it's very uncommon, but you need to investigate that. So sinus bradycardia, heart rate below 110, the rhythm is regular, and remember there is a centile chart for reference. What we need to think, it could be that if you have a slower heart rate, that the baby has a left isomerism or heterotaxia, because in left isomerism you have two left atriums, so you lose the right atrium sinus node, so the rhythm is usually an atrial rhythm. Not very common, but things to consider. What you have to think is inherited cardiac conditions, and that centile chart is helping to identify fetus that may have long QT syndrome. So long QT syndrome is important to look, to ask the woman about history in the family. Has anyone died suddenly? Has anyone kind of, every so often loses consciousness? History of sudden death. You have to think about autoimmune disease, so check maternal anti-Rho, anti-La antibodies, not very common, but it is also a cause of sinus bradycardia. So detailed history is important. You need to do parental ECG, not just the mother, the father as well, to look for long QT abnormalities or familial bradycardia, as I showed you, and check maternal autoantibodies. Obviously, how this is going to evolve depends on the cause of the bradycardia. So it's uncommon, but it's usually not benign. So it's usually a reason if it's a persistent bradycardia. So most of the time, these babies will be investigated after birth, and the whole family. So this is the same graph that I showed you before for fetus referred to long QT syndrome. The heart rate, baseline heart rate in them is, a lot of them are below the third centile. So this is the normal range, and that if you use this heart rate, you're going to miss all of those that have a relative bradycardia. Same group studying that. So if we have pregnant women and we have a baby with bradycardia, you have to say, could one of my parents be affected? So there's a lot of inheritance in these. Malignant arrhythmia sometimes can present with fetal bradycardia as well. So just need to think wider outside the fetus and into the family. So that's sinus bradycardia, not very common. The one that's quite common is ectopic triggered bradycardia. So because of blocked atriectopics. It could be regular or irregular, depending on how often the ectopics happen. If sometimes they're conducted, sometimes they're blocked. It can be all over the place. It can be a bit chaotic. And here we have two regular bradycardias that came out of place. One case is heart block, one case is atrial bigeminy. Not possible to distinguish between the two just by looking at it, both regular. So regular bradycardia, heart rate around 75, 78 beats per minute is typical of blocked bigeminy, but it could be a heart block. So we need to go through our following the same protocol. This is an M mode. You can see here becoming familiar, atriosystole, atrioectopic, in pairs, atriosystole, atrioectopic, but that's not transmitted to the ventricle. So the ventricle only see the normal sinus beat. So the atrium goes, and the ventricle goes slow. So that's atrial bigeminy. Blocked, but what is being blocked is an ectopic, so it's a physiological block at the level of the atrioventricular node. So this is most of the time benign, will resolve. The bradycardia can persist for weeks sometimes. You can have fetus with a heart rate of 80 for weeks, and they're fine. But there is a slight increase in risk of baby developing SVT because it has so frequent ectopic. So it does need a bit of monitoring as an outpatient, not because of the bradycardia, but because the baby could develop tachycardia, and that would require or may require treatment. This is how the blocked bigeminy would look on the pulmonary vessels. We have here an atrial systole, an ectopic, an atrial systole, and ectopic. If you look at this, and then you get used to that pattern immediately, you recognize. So normal sinus followed by a ventricular contraction. Atrial-ectopic, in this case, is so early, so close to the normal sinus beat that you have a reversed A wave, and it's blocked because the heart hasn't recovered yet from the previous contraction. So this is a typical pattern of blocked atrial bigeminy. And the same, it is blocking a pathological heart contraction of the atrium, but it's a physiological block. Heart rate of 75, this is different from the previous one, but it sounds the same. It would sound just like that. If we look at the M mode here, we have one contraction, another one, so it's regular. Regular means it's in sinus rhythm, but if you look at the ventricles, one is followed by ventricular contraction, one is followed by ventricular contraction, and one is blocked. So this is a block, but it's blocking a regular sinus node contraction. So this is a pathological block, so therefore it's a heart block. Of course, this is not benign. This is a malignant. Most of the time, this is associated with anti-Rho, anti-La circulating the maternal blood. Now, just remember that just occasionally you may have a 2-to-1 block like this one, atrium and ventricle. You can see this heart doesn't look normal, pericardial fusion, very globular. Just sometimes 2-to-1 block can be associated with long QT syndrome. So if you have persistent 2-to-1 block, to maternal ECG as well, paternal ECG. So fetal long QT syndrome, think about that. Now this is a similar trace that I showed you before, except now we have on the umbilical artery, we have a regular bradycardia. Before I showed you one that was in couplets. Heart rate of around 85 and 75, the two of them. One is blocked by Gemini, and one is 2-to-1 AV block. So there's no way you can distinguish that by doing your umbilical artery Doppler, your arterial Doppler in the aorta or pulmonary arteries. So you do need to have simultaneous recording of atrial and ventricular contraction. And if we look at these two M modes of these two babies, we have on the first one here, on the top we have the atrial activities. I labeled that, but it's easier to see here. We have a normal atrial contraction and a very early second contraction. So this is an ectopic, there's a gap, so they come in pairs. So this is atrial-ectopic, so close to the first one that it doesn't allow conduction. So this is blocked by Gemini, as opposed to this one where the contractions are here, and they are regular, and every other one is blocked. So this is a 2-to-1 atrioventricular block with the same signal in the umbilical artery. And that's how they look like on the pulmonary artery, pulmonary vessels, again the same. Atrial systolic, ectopic, atrial systolic, ectopic, and that is the ventricular contraction. It's becoming a bit boring, isn't it? It's a bit repetitive. On the second panel here, atrial, atrial, atrial. Sometimes for heart blocks, sometimes it's more difficult to identify the atrial waves. You're not used to that. So that's why it's important to do the two of them to make sure you don't misinterpret the information. But this again is regular atrial activity and ventricular activity, regular, but half the rate of the atrial 2-to-1 block. So of those two babies that I showed you before, it will be difficult to know which is which. But that one was blocked atrial by Gemini, so not much to do. And this one was 2-to-1 AV block linked to maternal anti-Rho antibodies. And then we finally have a regular bradycardia which has no relationship between atrial and ventricles, which would be the complete heart block. So the heart is usually kind of quite globular, but you do need to see simultaneous recording. Here we have the atrium going very regular and the ventricles going completely independent. If we stop that and try to time the relationship between the two, we will see there is no relationship between the atrial and the ventricles, so completely separate. So the ventricular rate here is kind of escape rhythm, and that rate could be as high as 90. I've seen a baby with a heart rate of 90 in complete heart block, and it could go as low as below 40. So it's quite a wide range. Most of the time it's around the 60, 65 mark. And that's how it looked like on a still picture, atrium here, regular, and that ventricle has no relationship. See, that one kind of coincides with this precedes that one, so you need to try and time, because sometimes this may still be a 3-to-2 block or a 3-to-1 block. So if there is any conduction, even if the heart rate is slower, it's better because at some point there is some synchrony between atrial and ventricular contraction. And in complete heart block, the clue here is that the pattern of the pulmonary venous signal may not bear any relationship with each other. See, this one is similar, but it's not quite the same as the other ones because the atrial contraction, the ventricles are all over the place. So when the ventricle contracts, it disturbs this, so you don't see any pattern in the pulmonary venous signal. I think probably for the complete heart block, the M mode has slight advantage over the pulmonary vessels there. Now we've gone through regular bradycardia. Now we are back on irregular bradycardia. So before we talk more about irregular rhythm, but it could be of that normal heart rate. So this is in that group in the middle in our flow chart where the heart rate could be around the 110, 115. Is this heart block or is this... so this is the same kind of flow chart I showed you before, but I'm going to break it down again. So this is your arterial signal coming like that. When you look at the pulmonary artery and pulmonary venous signal, we have the pulmonary artery here in pairs, just as you get in the umbilical artery, and then you have to decipher here the atrial activity. So an atrium here, atrium ectopic. So two normal, one ectopic, blocked atrial trigemini. We have two normal sinus beats, one blocked. It's in green because it's blocking something that shouldn't be there. So this is a physiological block, and it's a benign most of the time, but again, that risk of 5% of baby developing supraventricular tachycardia. So this is the same on the M mode. We have a regular interval here and an ectopic. Then there's a pause, a regular, and an ectopic. So coming in 3 with one very close together, and the ventricles go in 2. So this is blocking an ectopic, is blocked physiological. Now the same pattern of 2, not benign, second degree AV block. Again, you have atrium, 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 and that one is going to be a blockage because there is no conduction here to the ventricles of a normal regular atrial contraction. So this is heart block with the same trace. So these patients obviously do need to be assessed as a matter of urgency, and this is the same picture I showed you before, which is combining, because here this slide kind of forms part of the atrial ectopics, but it also forms part of the relative bradycardia. So one is blocked by Gemini and 3-to-2 atrioventricular block. So when we have that heart, what do you think this one is? Just by looking at it, there's not much way of knowing ectopic beats or heart block. This was heart block. This was a lady who was then shown to have an anti-LA antibodies. There was a Wenckebach. The PI interval was progressively getting increased until it blocked 1. So ectopic related bradycardia, blocked by Gemini, the rhythm is regular. If it is sustained, you can have short periods of that and it goes into sinus rhythm and then it goes into irregular rhythm, but I'm talking here about sustained bradycardia with a heart rate of about 70 to 80. If it is due to blocked by Gemini, it's obviously ectopic related bradycardia. You can have irregular rhythm because if it's irregular, some of them are conducted, some of them are not. So the heart rate is a little bit higher and it falls into that middle group. It's not normal and it's not bradycardia, not below 110, and it's not tachycardia. So that group is the group that needs distinguishing very carefully between ectopics with irregular rhythm and heart block, second degree heart block, which is not 2-to-1. The management, once you establish that it's due to ectopics, and that's the key, the management is conservative. You have to monitor intermittently for development of tachycardia, and there is no more than 5%. If you have short periods of tachycardia, obviously intensify monitoring. If you have a lot of ectopics, you should intensify the monitoring as well. The main message here is do not deliver the baby, particularly if the heart rate is around 70 to 80. Find other means of assessing fetal well-being. So heart block-related bradycardia, it's just a summary. Partial AV block with 2-to-1 conduction, the heart rate again very similar to the ectopics. Wencker-Bach, because it conducts some and the AV interval gets prolonged until one block, the heart rate is variable and again falls within that middle grade category there, 110 to 120, 117, 126 persistently. And complete heart block is a wide range here. As I said, I've seen complete heart block with a heart rate of 90 and as low as 40. The management, if it is block, pathological block, is obviously completely different. That's crucial to make the difference. You have to check maternal anterior anti-lie status. I'm not going to go into the details here. Steroids is very questionable. I think we should consider that if you have evidence that there is very recent onset heart block. Salbutamol to increase the heart rate if it's below 50 beats per minute. My experience is that it doesn't do very much. Some people use immunoglobulin. Plasmapheresis in utero pacing is not really a reality at the moment. But these babies will all require postnatal pacemaker at some point. Some of them require early in the neonatal period. Some of them can stay a few years without a pacemaker, but they will require a pacemaker in almost 100% of the cases. Now remember that if there is a previously affected child with heart block in mothers that have anti-Ro, anti-La antibody, there are some studies quite convincing. There was some studies that have just closed on the preventative use of hydroxychloroquine from even before the pregnancy, certainly before 10 weeks of pregnancy. So if there is a history of previously affected child, you do need to speak to your rheumatologist and consider giving the mother, if she's planning a pregnancy, giving her hydroxychloroquine to try and prevent or reduce the risk of recurrence of heart block. And that is a paper that, if you haven't seen, is worth looking, because it's kind of the beginning. And if you look, particularly Gilles Bouillon, who is the senior author there, has done a lot of work on heart block and all the studies on the hydroxychloroquine as a prophylactic for recurrence. So we are going to have to go fast now because it's tachycardia and also we're coming to the end, so we're going to speed up a bit. I think we'll finish on time. So tachycardia, there we are, clip. We're used to that. You can see there's a bit of pericardial effusion. So even if this baby goes into sinus rhythm, you would watch this very carefully. A bit of effusion, this is probably in tachycardia most of the time. So we have different types of tachycardia. Supraventricular, although atrial flutter is supraventricular as well, most of the time supraventricular, you're talking about others that are not atrial flutter. And there are different types: sinus tachycardia, re-entry tachycardia, ectopic tachycardia, and permanent junction reciprocating tachycardia. So SVT, atrial flutter, and ventricular tachycardia. So there's the three main groups. So it's important to know, and I think you all know, it can lead to heart failure. Yeah, if you think about you're walking is your normal sinus rhythm, you suddenly decide to jog a little bit, you can do that for quite a long time, and then you decide to run. Some people run a marathon, I don't know how they finish. So if you run and 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 run, you are going to stop, you're going to get tired. So if the heart goes fast, 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 it will tolerate that for some time until it gives up, it goes into heart failure. If it happens intermittent, like, it runs a little bit, jogs, it stops in sinus rhythm, then it can sustain that for quite long periods of time without going into heart failure. The problem is we don't monitor the woman 24 hours a day, so you have to have means of assessing how likely it is that this baby may have heart failure. Obviously, if you have a big heart, you have lots of tricuspid regurgitation, you have ascites, that's clear cut, the baby's in trouble. And if you see high drops, and you don't see tachycardia, monitor that baby, unless you have another reason, because it may still be intermittent tachycardia. So look for tachycardia in hydropic babies. So the treatment is going to depend on the mechanism of the tachycardia, so therefore we're going to have to establish what's the mechanism. On the fetal status, if they're hydropic or not hydropic, the gestational age, if it's very early, you're going to have to treat if you need to. If it's very close to term, you can deliver the baby. And maternal choice, because she's going to have to take medication she doesn't need. Usually most women would start on medication if needs treatment. So SVT with one-to-one conduction, atrial flutter and ventricular tachycardia, the three main groups. If we start with the supraventricular tachycardia, there are two main groups. There is one which we call a short VA interval. This is for those that want to understand more about the mechanisms of the tachycardia. And there is a group with a long VA tachycardia. The short VA is by far more common than the long VA tachycardia. And this is usually a reentrant mechanism between atrium and ventricle which perpetuates the cycle. And the long VA tachycardia could just be a sinus tachycardia, just a normal rhythm a bit fast. It could be an atrioectopic tachycardia, so the atrium sends a signal the whole time. And this is a reentrant tachycardia that's less common, involving the atrioventricular junction. So let's look at the two most common ones. This is a typical picture on the M mode of supraventricular tachycardia with a one-to-one conduction. You see here the M mode line going through the atrium and the ventricle. You have here beautifully the atrial contraction, and you have the ventricular contraction on the bottom. If we time them, they are one-to-one, and the interval between them. And then suddenly it goes into normal rhythm, and it could start again. So to treat this or not to treat depends on how to assess the fetal status. You can see here that heart looks a bit big. This is how the short VA tachycardia will look like on the pulmonary artery and pulmonary venous signal. You can see it looks completely different from the normal signal. It's sometimes quite difficult to pick up the arterial signal because it's going so fast, and you may just see this pattern here. If you just ignore the V, you may just see a to and fro pattern in the pulmonary veins. You can be almost sure that that's one-to-one conduction rather than atrial flutter. So what happens is this goes so fast that during atrial systole, there is reverse of flow through the lung parenchyma. So this is going forward towards the left atrium. It's the summation of S and D, and then during atrial systole, it goes backwards to the lungs, and this following the atrial, it goes back to the atrium quite often because there is a reentrant mechanism with retrograde conduction, and then it comes down through the normal pathway. So you have a short interval between the ventricle and the atrial activity, which is reflected in the pulmonary vessels. So this is often an accessory pathway creating the circuit for the tachycardia. So that is a short VA tachycardia on M mode and pulmonary vessels. Now these are long VA tachycardia. The mechanism is different. The reason for the tachycardia is different. It could be a sinus rhythm. Usually you have to, I don't have an example of that, but it's just a normal one, a bit faster. You need to think about maternal thyroid function, infection, temperature. This is a relatively more common as an atrioectopic tachycardia. You see here the pattern is quite similar to the normal pattern of the pulmonary vessels. The heart rate here is 192. It tends to be a bit slower than the SVTs. And if you measure the interval between the ventricle and the atrium, in this case, the ventricle is just a little bit longer than the atrial interval, the VA compared to the AV interval. So those are the two most common ones, atrial flutter and SVT with one-to-one conduction. And then we have atrial flutter. Atrial flutter goes most of the time, but not always, 2-to-1 AV conduction. That is, the atrium goes twice as fast as the ventricle, and the atrium can go as fast as 440, 450, and it can go as slow as 300 sometimes. So this is the M mode across the atrium and the ventricles in the case of flutter with 2-to-1 conduction. There's a bit of a pitfall here. If you don't have a perfect M mode, you can see that there are waves here, but one is bigger than the other in amplitude because one is conducting, one is not. So the reflection in the atrial walls is different. So if you're not careful, or if your signal is not very good, you may just pick up that one and think that you're having a one-to-one conduction. And this one you can see here, that's not the case, yeah? And that's how it looked like on the pulmonary vessels. It's completely different from the one with the one-to-one conduction. Again, you have one higher amplitude, one lower amplitude. These are all reversed A waves into the lungs, and one of them conducts, one is blocked. So the ventricular rate here is half the atrial rate. Completely different from that because it's going so fast. And finally, we have ventricular tachycardia, which is not very common. This is the same example as I showed you before, and you have to think about long QT syndrome if you have 2-to-1 block or if you have tachycardia. This is the same fetus I showed you before, 2-to-1 block, and now flipped into ventricular tachycardia. You see here the ventricle is going faster than the atrium, so it's overtaking the normal rhythm of the atrium. The atrium is fine, but the ventricle is going faster. So this is usually associated with long QT. So the treatment will depend on the mechanism, SVT or atrial flutter, the fetal status, if it's hydropic or not, and as I said, gestational age and maternal choice. How do you assess the fetal status? Well, obviously, if there's high drops, it goes without saying that's a baby that's unwell. You look for cardiac compromise, sometimes subtle signs like cardiomegaly, AV valve regurgitation, fluid collection, abnormal function. No compromise, no heart failure, but if sustained tachycardia, more than 50% of the time, you may be picking up that at a very early stage, so it's more than 50% of the time, or if you're worried, you may have to start treatment even without compromise from the cardiac point of view. I usually take a conservative approach. I might admit the patient to hospital for a day or two to monitor more often, to see how often the tachycardia is happening, and we have got away without having to treat some of these intermittent tachycardia. So management is most of the time transplacental. If you're in trouble, you may have to go to direct fetal therapy, delivery, depending on the gestational age, and conservative if it's not causing any problem and is intermittent. Transplacental treatment, the most common drugs used, digoxin, flecainide, sotalol, direct fetal therapy, digoxin, amiodarone. If we go through those initially, I'm just aware of the time, because this is another session. SVT with one-to-one conduction, I'm not going to go into these details here, but it's not clear-cut which is the best drug. Flecainide seems to be a good drug for most of the tachycardias, but not always. Digoxin, probably quite good for atrial flutter, but not always. If the baby is hydropic, then digoxin is not a good drug. I'm going to skip some of these here, because I just want to briefly mention there is currently a randomized control trial for treatment of fetal tachycardia, which has 3 main groups looking at flecainide, and you can have these through the web. Usually it's 100 milligram 3 times a day. It's usually a very good response. I always treat the patient in hospital to make sure the baby, the mother and baby are well, usually for a few days. Levels are okay within about 3 days. It has a good transplacental transfer, so it's well tolerated in general, and has good response in high drops in a lot of the cases. Digoxin is not a good drug on its own if the baby is hydropic. Most of the time we do a loading dose, and the dose I'm giving you here are the doses used on the trial. If the baby is hydropic, you go more frequent, the 2 milligrams over 8 hours. If it is not hydropic, you can use it every 12 hours. Obviously, you need to monitor digoxin levels and keep it at a high level. Sotalol is a drug that's referred by some people. It needs quite high doses. You don't monitor the level of sotalol. It has good placental transfer. It prolongs the QT interval, so you have to monitor that. Amiodarone is not used that often anymore. And I'm just about to finish because I'm very aware of the other session as well. So these are the 3 arms of the randomized control trial. If you search fast therapies trial, you can see that on the web. So one is for randomizing digoxin and sotalol for atrial flutter without high drops. The other one is randomized digoxin and flecainide for SVT without high drops, or a dual therapy if there is high drops in SVT, digoxin and flecainide, and digoxin plus sotalol. And that's the end of my presentation. I hope you enjoyed that. Thank you very much for your attention.